Hi, and welcome back to another PCBH Corner. I'm Dr. Bauman. I'm alongside Dr. Beachy. One of the things that I was hoping we could talk about today, my mind always says this kind of sounds bad about labeling things as like subtle deterrents or things that BHCs or behavioral health providers working in primary care do very subtly to deter almost the uptake of behavioral health services. And I know you have some ideas about this. What comes to your mind when you hear that, like any subtle deterrents that you think are common for BHCs?
And I know us as BHCs, we normally like to take things and put it into what you should do versus what you shouldn't do.
We're going to be a good behaviorist, yes. Yeah, let's do that.
And at the same time, I think that when it comes to getting involved in handoffs and making yourself available in clinic, a lot of novice BHCs kind of look to what can the team do, what can the system do to help me, kind of versus taking the more of initiative of what can I do.
Yeah.
And so if you start looking at what BHCs who are successfully incorporated into the clinic versus BHCs who struggle, you're going to see some patterns. So some of the patterns that you see is what I call the bird in the hand rule. So you know the old adage, bird in the hand is worth two in the bush.
Yeah.
So when it comes to different aspects of the clinic, if there's, say, maybe a scheduled patient, you'll see lots of folks who will not take a handoff probably 15, 20 minutes up until that scheduled patient because, hey, I have a scheduled patient come in. So then they do not take that handoff and then say, for example, their scheduled patient doesn't show. Well, now you just went from at least having one to having zero. And then if you're able to get through the warm handoff in an efficient manner, and then you're, say, 7 minutes late for your scheduled visit, you now have two. So it's just a way of making yourself efficient and available in the clinic. And when you say yes to handoffs, then it makes people more likely, as we know as behaviorists, to continue to utilize you.
That's what my mind was going to as you were talking about it, is that at the most basic level, taking the handoff reinforces the behavior of the provider giving the handoff. If
Correct.
It's always like, oh, I can't do it for another 10 to 15 minutes because I'm waiting on this scheduled patient, that behavior of the PCP giving the handoff is going to go extinct.
Yes.
You know, my mind was also thinking, as we're having this conversation, about another subtle deterrent that I often see is almost, when a handoff comes, almost taking too long to get into the room.
Yes.
Right. So, and I've seen this before, and it makes sense. And I think as we laugh about this, there's a sense of like grace and kindness that I think to have for the BHCs. This is a difficult situation because it's not the way that we're trained. You know, if we get a handoff, almost in a specialty realm, it's like we got to learn everything. Like let's do a chart review. Let's take our time and have all of our wits. But it's something that does, I think, deter.
Essentially,
handoffs.
if you're him-hawing around,
right.
At a certain point, the physician's ready to go, the MA's ready to go, the nurse is ready to go. And if it's like, oh, I have to review pages worth of records before I can get into the room. So, of course, we're not saying to be negligent, but yeah,
I've seen it. I've seen it where nurses are like, are you going to see that patient? Like after the handoff is done, the nurse is like, or MA is like, hey, are you going to see that patient? You're going to get in there? Like almost like signaling that.
And if every time it's a huge process, then here we go, we have ourselves a subtle deterrent. Because of course in that moment, the BHC, as we're saying, they want to do right by the patient, they want to do right by themselves, and of course we're in favor of that. But if you're taking way too long and trying to gather all the information, you're not, first of all, it's not even feasible, and second of all, you're making it such a long process for the physicians and the nurses and the staff that over time they just honestly get tired of dealing with it.
Now my mind has come up with another one, as you were just saying that as well. And I see you doing this in a good way, not in the deterrent way, but more in the willing way, about just how you operate in the medical pods. That, when you go into the medical pod, you're talking with other providers, you're talking with other MAs. And even if you're sitting down, if someone walked in, they would definitely say, like, she's part of the team. Like she's part of this. And I've seen the opposite with other BHCs where almost when you walk into the pod and you see everybody there, you see someone like off in the corner. And my mind always goes like, I don't know who that person is, but they're probably not part of the team.
Yeah, they're not a part of the process that's going on in the workflow.
Yeah.
They're kind of exactly buried in their computer. So if you're kind of literally physically closed off, buried into your computer, and you're still like, well, hey, I'm not on the medical team. Somebody can get me for a warm handoff at any time. It's kind of really, how open are you? How approachable are you versus you're standing? I honestly recommend to stand, but I might be too strict about it. I'll just kind of take my laptop and put it on the counter, and I'll stand and kind of really have physically an open stance.
Yeah, like literally, like an open posture. And we couldn't go a whole PCBH corner without talking about context. And it's almost creating a context of people being able to approach you.
Yeah, if you're standing up and you have your computer nearby and you're making eye contact, you're checking in with folks, that is a very different experience of being in that medical pod than if you are kind of plopped down, closed off, buried in a computer. Again, not saying you can't do some chart notes, not saying you can't answer an email.
Exactly.
But you got to really think about what kind of vibe are you giving off?
What kind of context are you creating, essentially, for that? Okay. These are good. These are really great. And, I would say for the people watching this, if you have thought of other subtle deterrents, put them into the comments. Obviously, email us, because I think it's a common thing that probably we experience very often, and we should definitely be sharing this with everybody.
And to, of course, be behaviorists and make it what you should do, in summary. Having that open stance, making eye contact, checking in with the team, taking handoffs in a more quick manner, or at least in a manner that isn't really holding up the entire team.
Process.
Yeah, the entire process. And then if it's a little bit closer to where you have your scheduled visit, or heck, your scheduled patient is there, go ahead taking the warm handoff. And so you're going to procure that one, and you're also going to get the scheduled patient. And if they do no show, that's okay. Then you at least made sure that somebody was seen. Because at the end of the day, what are we trying to do with primary care behavioral health? We're trying to increase access and make sure that the medical providers and the whole system are, in fact, supported.